Hello everyone, welcome to a new episode of Retina Chats with me, Dr. Mustafa Manhali.
Hello, everyone.
Dr. Mustafa will present his case now. So tell us more about this crumbled retina.
This is a 19-year-old uncontrolled type 1 diabetic patient that presented with a diminution of vision in her right eye, and the left eye was neglected for 1 year with hand motion vision. In the right eye, she just had a diabetic macular edema, and she started to have an intravitreal injection according to DME protocol. But the left eye showed this kind of tractional detachment, and after counseling the patient that there is a possibility that we may save this eye even with counting finger vision and to avoid any long-term sequelae of neglected retinal detachment. So we proceeded for this kind of vitrectomy, and the message in this case that I usually tend to remove most of the membrane that I can using the cutter using a unimanual dissection. But in this case, as we are seeing that there are a long and broad attachments of the vitreous, and doing the PVD using the membrane just by pulling, I can proceed to just clear over the macula, but with the membrane folding the retina under this broad attachment, it's very difficult to undermine or under dissect this membrane using the cutter or even the scissor alone.
Okay. So it's a difficult case. You were asking me before we record that would I consider this case operable
Yes.
and inoperable? I usually I would consider it operable. I would counsel the patient very well that vision may not improve that much, but at least we have an eye that if it improved a little bit, then we have an eye that is like a reserve. If the
Yes.
other eye anything is to happen to it, if there is a vitreous hemorrhage, if there's anything, then she would be able to see with this weaker eye if something wrong happens with the other eye. So now I see that you're shifting to a bimanual
Yes,
technique.
because
Yeah.
I tried using the unimanual, but in this case, it's very, very dangerous, even in this crumbled retina, to remove any vitreous over the retina and to induce any iatrogenic breaks. So I have to be very cautious and to remove the membranes using this dissection, and to go in the right plane and to remove the membrane by cutting using the scissor, cutting this broad attachment. And the
Okay.
direction of inducing or introducing the scissor under the membrane differs from area to area. Now the scissor is bevel up. In some situations, I'm
Yes,
going
you
to,
just shifted
yes,
the
yeah,
scissors now.
just to keep it away from the retina and to keep the cutting edges from the retina as much as I can.
A very nice technique. I'm just thinking now that there might be a layer of posterior hyaloid on the superior part of the retina that wasn't addressed. So I know you're not a triamcinolone guy, but in this situation, I would inject triamcinolone, try to highlight this thin layer of posterior hyaloid. It may give me an edge to dissect this membrane from superior to inferior, or from outside to inwards. But you're doing a very nice job, and you completed the dissection very nicely using the bimanual technique. Very nice technique. I see that you've managed to remove the whole membrane.
Mhm.
Um, but the macula is dragged upwards. What are you going to do to flatten this
I
macula
will.
or to
There
position
was
it in
a
place?
Yeah, there was a break during the peeling of the highlight from this thin retina. So I used to just to remove all the subretinal fluid from this space, so I may try to lay down the retina back. But regarding the shifting of the fovea or the macula, probably I cannot fix it at this moment.
Okay.
And that was my question, that foveal displacement that was present due to the tractional retinal attachment. Even if we try to fix this retina, is it valuable or sufficient for this patient? Because if there was improvement in the vision, it's going to be not straightforward. It's going to be an eccentric vision in those
I would
cases.
still try to fix this eye, even if I know that she will have an eccentric fixation. I'm not sure. As I said, it's just a reserve eye if something happens to the other eye. Some may tell you that if you do an ILM peel here, the retina may become more and more elastic and it can flatten in a better way. Do you believe this
In
is
diabetics, I don't believe so.
Yes, I'm not convinced with this opinion, but I have to just get it out there that some people that believe that ILM is the cure for everything, ILM peeling. So you're not with this opinion, right?
It wouldn't add for diabetics, especially with this displacement, whether we remove the ILM or not.
Okay,
So this case was finalized with silicone oil
okay,
tamponade, and this is the 1 day post-operative.
okay,
The retina is flat under the silicone with minimal hemorrhage at the area of dissection, and the laser in the inferior and temporal parts only, because the other area, whether superior or nasal, there was a still minimal subretinal fluid, so I couldn't able to add the laser at that time. So after 4 months, the patient presented with a counting finger 2 meters, and she was planned for cataract removal and silicone oil removal. And as we can see, the retina is flat, and the fovea is in place and much better than the look that we left the patient at the end of the first surgery. Then we started to add the laser at the nasal and the superior part, and the vision is now 0.05, and she's stable, but with an eccentric view, which is she's happy that she regained some of vision in this eye. As you said, this is just a reservoir eye, and for me, we avoided a long sequelae for glaucoma, for atrophia, and even the change of the appearance of the eye.
Yeah, I believe this is a complete success, and the vision didn't improve that much, yes, but it's a successful surgery. There's no major complications. There's no redetachment, no reproliferations. You benefited this case definitely. Um, as for the eccentric fixation, well, it's not uncommon to have intractional retinal detachment cases, and it's not your your fault. It's the
Yes.
patient's bad condition and neglect of the tractional retinal
Yes,
detachment.
this is one of the scenarios that we see, especially in type 1 diabetics, and because they have a very aggressive kind of detachment and traction, especially with uncontrolled diabetic level due to puberty, hormonal changes, and their young age.
Okay, so I believe this is a complete success, and the most important part in the surgical technique is the bimanual dissection.
Yes.
It saved the retina. It decreased the instance of
Breaks, yes.
iatrogenic
I
breaks,
believe
and
this is a mandatory case for bimanual.
yeah,
Yes.
exactly. Okay, thank you very
Thank you very
much.
much.
Thank you. Stay tuned for the next one. Thank
Thank
you.
you.